Hopefully, I don't get any of my information stolen.
Yeah.
All right, so let's. I got this recording.
Mm,
Let's see. Let's start with just a couple of the ground sitting assessments.
okay.
I just want to explore a couple things and see if it makes sense for something that you can use as a test retest, like comparison for yourself.
Mhm.
How's the gymnastic body stretching going?
It's good. I've been messing around with mainly the what is it called? Like the front back split one.
Mm-hmm. Yeah.
That's one I've been messing around with the most, and like trying to get into that. Um, Mainly been trying to just get into that position somewhat often, like kind of the couch stretch against the wall to a point.
Yeah.
That's pretty brutal for me to try to get into, but I mean, it feels good.
Right.
Yeah.
Yeah. Just be willing to make it easier. It doesn't. It's not like meant to be brutal because then you won't be able to breathe there and things
Yeah.
like that. So the recommendation that I would use is I think it's good to have your shin all the way back as a like anchor. But if you feel like your butt and your heel can't come away from each other
Mhm.
and you can't even think about getting upright, that's fine.
Yeah. That's sort of where I've been.
Yeah, use yoga blocks and then make it more of a think of it like a Jefferson curl in a split position where you're curled down at first, trying to prioritize the expansion posteriorly. Like you just don't want to lose that element, and then you're thinking about eventually you're rolling up without losing the pelvis.
Yeah.
So you're not going to be able to move very far, and if you try, you'll just lose the orientation right away.
Yeah.
So the stretch is, I mean, you'll get the stretch early on. And that's, I think, the goal is to try to get the stretch as early in the process and up as high as proximally as possible without having to feel yourself go upright.
Yeah.
Because as soon as you go up, yeah, you'll get the stretch when you're up there and it'll feel good, but you're almost guaranteed that you lost your orientation.
Right.
So I would explore that. But then you can also work from like the other direction. Just say like, okay, you lost the orientation. You're going to get upright, like holding on to something, and then try to actively move yourself back into the other direction to find that orientation and just see what that feels like. So I think there's some value there to just having that anchor, and just as long as you know what you're going for. Sometimes you might want to use video. Sometimes you might want to use like a mirror or something, just to kind of get a sense of it.
Yeah.
But you're ultimately like trying to. Have you done Jefferson curls?
I haven't actually done them, but like I know what you're talking about.
Yeah, or just without the load, just think of it as a roll down.
Yeah.
You just happen to be starting in that split position, so you're rolling down, and when you're rolling up, you're trying to segmentally go from low to high, and then high to low on the way back down. And you'll find as you start to do that, there's going to be a point where you can't go anymore, and that's where you want to stay and breathe and feel the expansion on the backside, and then feel the compression on the exhale, and both of them will work in getting you where you need to be on that.
Yeah.
So I think that makes sense to spend a lot of time there, because then that's sagittal plane.
Yeah.
But all three of the programs have like different things to focus on. So I think the thoracic bridge stuff with your shoulder work, when you find both when your hands are going behind, what you're going to feel a lot is compression here and here, right? So you're going to dump here, and if you can feel when the onset of that is, and the head's going to want to kick forward too. And if you can feel the onset of that, again, you have an anchor with your hands behind you. Now your focus could be on getting some inhalation moving forward and high, and I think you can get that in a way, or you can experience that in a way that you won't be able to feel without that anchor with the arms behind. And then the closer you get your pinkies together, so they promote a lot of external rotation, supination in a shoulder extended position, which is, almost it's counter, right? Like, so normally when you go extension, you would want to go pronation, internal rotation, and if you try doing that, you'll find it's a lot easier to get your arms back there. But at the same time, they're not in the gymnastics world. They're looking to kind of free up everything, right? So when you go supination and extension, it's harder, but it gives you a little bit more of an anchor sometimes, and you just have to be more patient with it because your elbows can start to talk to you. It's oftentimes you're going to just be limited by not being able to supinate, so you won't be able to have that anchor. But it's irrelevant. It's just like take yourself to where you feel that you're limited. Be okay with it not being very far. And as soon as you start to collapse here and you start to feel like some movement through there, there's a lot of value to that. And that carries over to like any dip position where your hands are behind you and then you're starting to bend your elbows, because as you get lower into a dip position, you'll see the same thing where it's just like the cave happens here. And that's usually when you've lost your full internal rotation. So if you just pause there and then you feel yourself expand from the front, and then, you don't want to lose the backside either. So it's not like you're pushing yourself forward. It's just that you're breathing yourself forward. Yeah. There's a lot of opportunity to free some stuff up. And then it kind of ties into maybe some of the stuff you would already be doing with bodyweight training.
Yeah, no, that makes sense.
The other one is like horizontal adduction positions where they have like the capsule stretch. And then they also have the one where you're in the like lumbar locked, like child's pose position. Mm-hmm. That contact here coming across, that could be a lot of pec at first, but then there's an opportunity to feel yourself inhale into that and create space where otherwise it would be just jammed here. So you got to be careful with that because you certainly can get a lot of pinching. But if you can breathe the pinching away pretty much, and you'll feel with almost every breath you're able to get farther, this side starts to open up, right? You start to feel the scapula going across a lot more and staying on the rib cage. But here it's almost like you're breathing away from the impingement that you would expect there.
Yeah.
And that could be really valuable to feel like that free up, right? That pump handle there, IR, but you're also opening up the backside at the same time. So like it's very localized, like AP expansion, just because you've jammed that compression, just like at the bottom of the squat. If you feel like the onset of hip compression anteriorly, and then you're able to have enough support where you're not like guarding there, and then you're able to inhale, front and back. You give everything a little bit of space. It oftentimes allows you to get a little deeper.
A little farther. Yeah.
Cool. So I think seek those things out.
Well, I might play around with that one next today.
Okay. Yeah, and what you'll find, and I'm definitely doing this, is the ones that make the most sense for me to do the most frequently, instead of going through the whole program, every time, you'll find the ones that like make the most sense to where you're limited. Mm-hmm. And especially from a breathing perspective, it's certain ones I think give you that opportunity to not compensate, or when you're compensating better because there's so much compression and feedback. And then those are the ones that you can just be going after, like a grease the groove idea of just like often they're your assessments, but they're also your treatments. Mm-hmm. Okay. But I like having the versatility of the whole program at first, because you don't know where movements are going to be. But if you have the fundamentals of what you're trying to feel and how to breathe and how to move pressure, I think it makes it a lot more valuable to do a stretching routine like that. Don't think of it as stretching. Just think of it as position and breathing, right? Mm-hmm. You're positioning yourself. You're looking for any onset of something that you don't want to feel, right? But you might go into that, and then you can see if the breathing allows you to go farther without that symptom. And I think there's a ton of value to that.
Absolutely.
So let's get on the ground. So just tip everything down. And if you can also be by a wall, I think a wall will really help with what we're trying to assess.
We'll see how this looks. Oh, it's a little. Does that work?
Yeah, that'd be fine. And just, if you could put your back against the door, that should be fine. As long as you have enough room for...
You want to get to this door?
Let's probably use the one to your left. Yeah. So, all right, there you go. Just because your knees are going to need to go out. All right, so first position, actually, that's a good one for you to start in, a long sit. So think about a long sit as like a bilateral straight leg raise. All right, and then you know what? I'm going to put you in gallery view because if I'm talking, I won't be able to see this in the recording. All right. So you want to feel like where is your sacrum? You know, where is the base of the sacrum? And then your goal before you think about anything with straight legs would be, can you get the base of the sacrum or like the back of the waistband flush against the door, flush against the wall? So that's going to be your fight.
Yeah.
And you can use reaching. So if you put your hands into the ground, think about like what direction would you need to reach to get the base of the sacrum more into the door, right? And that would be what you're experimenting. So right now your arms are in that a little bit in front of 0 degrees, right? But you don't have to like be in any specific degree measure. You just have to put your hands where it's easiest to get that trajectory of the sacrum back. So you just explore that a little bit. Once you feel you have that, and then maybe bend your knees to start and just see if it's easier to get more contact with more of your spine, right? So have you done you've done the FMS, right? We've done that together.
Yeah.
You know, like the stick, the dowel on the head between the scapulas, and then usually they'll say like down by the coccyx or something on the sacrum. Well, think about the same idea here, but we just have more of a broad contact, right? And you definitely would want to bias more of the base of the sacrum than the coccyx, right? Because if you get the coccyx there and the base of the sacrum comes off, now you're going into too much counter-nutation extension.
Yeah.
All right. So, like, I think it's just good to use a wall as a basis for everything, and you'll feel much more restricted. Yeah. All right. So you get as much as you can there, the back of the head lightly, the area, the dorsal rostral between the shoulder blades somewhere, and then the base of the sacrum, and then as much of your lumbar region as you can. But you can't force anything too much or you're going to lose the other stuff. So you just have to sort of find that equilibrium there, that happy medium of getting as much contact with the door. And then try to straighten the legs all the way and stop whenever you feel like you lose any of that. Right there?
Can I be actively pushing myself up a little bit?
Yeah, I mean, this is where the reaching comes into play. You can experiment with, you know, turning your hands different ways, like whatever feels like it wants to come off the door, you can reach in a manner that keeps you there.
Yeah.
But you want to notice, like, if you're straightening your legs, there's a relationship between that's going to want to pull you off the door.
Yeah.
Right? So that's basically what we would be measuring. But then from just an exercise standpoint, you can say, all right, now I want this relationship of being able to straighten out my knees, right? So that's going to be extension of your knee. That's also going to be like more lock home of the. Are you familiar with the lock home mechanism?
I think a little.
So when you straighten your knee, the tibia should go into lateral rotation, and then relatively the femur will go into more medial rotation, right? But it's just this is going to be more of a compressive strategy to try to get extension there. So I would focus more on a long exhale, a compressive exhale, ribs down, pelvic floor ascending, while you're still trying just not to lose that contact. All right, so your major goal is just don't lose that contact, but your focus may be a little bit more on the exhale. It doesn't mean you don't breathe in. It just means that what's going to get you there would be probably an exhale where imagine what happens to the pelvis during an exhale when you're in that position, right? It's going to be more like IR'd. You're going to have more of the idea of an ascension of the pelvic diaphragm, or anteriorly at least.
Yeah.
Okay, the inhale still, you want to push that sacrum back. You just might not feel it as well there as you feel what's happening during the concentric exhalation.
Right.
Does that make sense?
Yeah, especially because if I'm like it's in that sort of IR range to begin with.
Right. That's what. So then you're always breathing in both phases, right? You're always inhaling, you're always exhaling. but certain positions will make you maybe want to focus on one over the other, right? And in this case, you're going to get more in the direction that you want to go, that you're limited by being a little bit more pressurized with your exhale, being a little bit more, ribs down, belly button in, really feeling the concentric pelvic floor action. Where if we're in the more bottom of the squat, whatever you can get, or if you're in that kind of deeper hip flexion position, you're still going to think about those things on the exhale. It's just not, it's going to be harder for you to feel them. So then the inhale will be easier to feel. The opening, the expansion will be easier to feel. All right. But this is a good assessment for you to get a sense of like, all right, can you get those knees straight and straighter over time without losing that contact? But the breath is the work, right? And then all of the core musculature that goes around the exhale is the work. All right. You don't do this in isolation. So say you suck at like doing all those things on your exhale. Well, then this isn't going to be a great exercise for you, but it doesn't mean you don't try it. It just means that it just doesn't happen in isolation.
Yeah.
Okay. So if you notice that like when you're doing something like this, you just don't feel like you're doing anything in the direction you want to go, then maybe don't spend a lot of time there, and it just becomes more of an assessment. Okay.
Yeah.
But I find this stuff really valuable personally, to just put myself in that that relationship, having the contact with the wall, so I can really feel as soon as something wants to start coming off, like where am I? And then can I use my breath to bring myself more into that direction? All right. So now let's take that same contact with the wall, and then let's put the heels together like more of a butterfly position. All right. And try to keep just heel contact more than like the whole foot together, because if you try to go whole foot together, you're going to invert a lot.
Yeah.
Okay. So you just want to feel like this is happening as much from your hips as possible. Obviously, like the knees are involved in things like that, but you get a sense now if you're moving into ER, you still want the same feeling of contact with the door.
Yeah.
And then you're just going to focus on the same breathing. Now here, maybe the inhale is more of your focus. Like, can you feel your inhale lower, like descending the pelvic floor a little bit better than you could in the long sit position?
Yeah. I mean, in this position in general, it's way easier for me.
Okay. Yeah. So that's, and that will get you more eccentrically oriented, right? Because we're going into more ER, right? But you still need that contact with the door, because it's super easy to compensate, right, with your pelvis.
Yeah.
Or your lumbar spine, or somewhere in the spine. All right. Now, with these positions, I would focus a lot on what's going on low. Like, what's going on with the sacrum into the door? What's going on with, like, you visualize actually the idea of external rotation. The femur is rolling out as you inhale, maybe a reaching idea of the femur. And then if you feel that's more comfortable, you start to build up the expansion, right? So now, okay, I'm getting pretty good at moving the base of the sacrum back into the door. I feel that there's like there's an AP expansion too. So it's not just back, right? Like, you're not trying to collapse at any point. You're just trying to feel maybe, what's going on, the belt buckle in the front moves forward as the back of the waistband moves back. But as you start to feel that relationship better, you start to feel the descension into the pelvic floor. Well, now maybe you extend that slow inhale up a bit, right? You start thinking about, okay, can I expand into the dorsal rostral? Am I losing anything in the pump handle? And you may reposition your hands depending on, like, if you need your hands there, otherwise you're going to fall away from the door, then you keep them there. But that also gives you some information about how stable are you with those mechanics, right? So you can start moving your hands a little bit forward, which is going to start to bias more dorsal rostral. But if you can't keep what's going on lower, then that just gives you some information. That's also part of your ongoing assessment.
Right. That makes sense. I noticed with this one too, like, just it's almost natural with external rotation, even though I'm still in this further back extended position, like just going to the outside of my hand
Right.
without even really thinking about it.
Yep. Yeah, and just that subtlety of exploration can really help depending on what you're trying to bias.
Yeah.
So if you're trying to, bias moving maybe the chest forward a little bit more, say you like were awesome at keeping the upper back there, like you didn't have to work real hard, which is not going to be the case, but just let's say you were, but you felt like you were a little bit limited in the front, then maybe you might start going to the thumb side of the hand.
Yeah.
And you just explore that. But
Well, on this one, on the long seat, it's just more natural to go. It just feels more natural to go more thumb side.
Yeah.
Which, I mean, yeah.
Yeah.
Which
But
is-
where you want to just be careful is that you have to keep that unshrug.
Mhm.
Okay, so that's just something to be cautious with when you are using when you're using the door there, when you're using the wall, is there's going to be a ton of places that your body wants to compensate. So it's smart to me to use as much contact points as you can so that you only have to think about a few compensations, or like you just have more feedback of loss of posture. Because I mean, that's ultimately what we're trying to control with people is where are they losing their posture and get them to be better at that. And again, loss of posture is not necessarily there's a right posture and a wrong one. It's just, there's some relationship there that we're seeing and maybe the client isn't seeing. And very often they're not seeing because they won't have the education to even think about it. So just giving them some awareness of that verbally can be step one, but that may not make any sense until you put them in a scenario where you have all these contact points and then you give them, a scenario where it's like as soon as you lose one of these contact points, that's as far as you can go.
Yeah.
And then what do you have to do with your arms to keep those contact points? All right. So you're basically giving constraints, you're giving rules, and you have to stay within those constraints for the exercise and for the assessment to take hold and to be accurate.
Mhm. Yep.
All right. So that would be your ER, and you can see where that would go, right? Like you would want your knees to go more to the ground, but you'd also maybe want your feet to be able to come a little closer to your groins. It's an ongoing process, but just spending some time there and not even focusing on the opening as much as you're focusing first on the expansion back into the door and making that easier and easier, I think you'll find more and more value. And you'll just notice that the knees will start to drop more and more over time as you get more expansion back.
Yeah.
And then you get an appreciation for head position too.
Yeah.
Right? So if it's hard to get the head there, that's like don't overwork. And it's for some people, you may need to just say like, all right, you don't need to touch the head, or you put something there that the head's a little easier to touch. But it's okay to have this little chin lift, as long as the jaw isn't protruded this way, right? And you don't want it too far forward, but it won't be too far forward if the head is touching. So if there's a strain though, and it's harder to breathe, that's where the head position is not ideal, right? Mm-hmm. So it has to do with how easy is it to breathe. If in order for me to touch my head back to the wall, I have to really kink the back side here, it's going to be harder to breathe. But it's also harder to breathe if I'm really doing this. Mm-hmm. So there's this midpoint with an inhale that you want to be, which is going to be like that little chin lift idea. So just a little bit of contact with the back of the head may put you there depending on what's going on down the chain. And that's something that, I think you're aware of your body enough to be able to make an adjustment to. You just don't want to feel like you're straining anywhere too much because you won't be able to breathe. And the key is the breath and duration, right? Like you got to be able to spend time there. So if you can't breathe well, you're not going to be able to spend time there. But I think that's a position that it's actually pretty easy to spend time there, focus on your breathing, see all the relationships happening. You'll even feel your asymmetries. Like you have sort of an anchor of spine, central spine and sacrum on a contact point. Mm-hmm. As you hang out there and you're trying to do a bilateral action with your hips, you'll start to feel that where the asymmetries are, like either one side won't drop as much, or when you have them even from where the knee perspective is, then you start to feel how your body needs to shift somewhere in the sacrum, one side versus the other.
Mm-hmm. Yeah.
And so the key here is like, is this something that you think your patient or client would have enough awareness to make sense of too?
Yeah.
Like, I think for you, yes. And I think actually for people that are, they're hypomobile, this sometimes might work decently well, because you can give people, like, you can give them supports, you can give wedges and things like that to have contact points, and then it is a position that somebody could maybe rest in a little bit better than going into a stretch that's pretty intense, and then there's going to be that tendency to just over pressurize. Where here, if I give you enough support, now you actually have an opportunity to maybe relax into that.
Mm-hmm.
So,
yeah, makes sense.
So that would be one, and then what you can expand on the butterfly by going into more of a cross-legged position. So let's just try to put everything back on the wall like you had it, and we'll just start with like a regular cross-legged, like you have it there. Mm-hmm. And can you still keep contact? Is it easier or harder than it was with the butterfly?
Easier.
Easier. Okay, makes sense. All right, and then the extension of this, and just see how this feels on your knees and on your hips, would be clear your right leg out for a second and put your left leg all the way on the ground. Okay, so you want the outside of the left thigh and knee on the ground, and still put everything flush on the door. Okay, can you get it there?
It's definitely harder.
Okay. So the progression here would be, all right, you want to maintain that contact of the sacrum to the door, and now you try to put your right ankle or your right shin on top of your left leg. It's like a half lotus. And you may not be able to get there, right? Yeah, you can get there. But what happens when you do that? Do you come off the door?
It's like, this is easier than having one leg straight.
Okay. Yeah, so this...
Both are harder than regular cross-legged.
Regular cross-legged. But I like this position if you can get there, because things are a little bit more in contact, they're a little bit more anchored. Make sure that your lateral malleolus on the right is outside of the left thigh, so you're not inverting your ankle. Okay? Mm-hmm. Just so you have like that. Now it's actually the leg bone that is in contact with the thigh, and you're not in some movement of the ankle. Does that make sense?
Yeah.
All right. And then you try to get all the same contact points, and then you can see now it's just the right side that you would have to assess how close was that, or how far is that from the ground? How much freedom is there?
Not. I'm pretty far. I mean, like, I feel it here on the right side.
So this also allows us a little bit more of a one side at a time assessment.
Yeah. So
think about you can assess ER on both sides, like, right? So your left leg and your right leg are in some version of relative ER, compared to, say, like fake neutral, right? With your knee and your hip facing forward. But what you want to look at is when more of the pelvis on one side being back into the door than the other, more heaviness on one side, that would be telling you that it's easier to get into ER on that side than the other. Right, like a more posterior orientation or more posterior contact on one side of the pelvis than the other. So when you try the other side, see which side it's easier, and then we'll also see if there's just an easier time, like having one of the knees drop closer to the ground than the other.
I mean, I think this is easier. Definitely easier with the left leg on top.
Okay.
Just how it, but like it just feels, I don't know. It's easier to keep contact with the door,
mm-hmm.
But if my left leg's on top here, it doesn't drop as much relative to when the right leg's on top.
So you're saying that's easier to get your left hip into the door?
No, I'm saying like on this,
Yeah.
on either one, the down leg, the one that's on the ground, tends to be the one where I feel like that sit bone is taking more
Mm-hmm.
weight on it.
Yeah, it makes sense.
So that down leg is easier to get into the door.
Okay.
Like it's easier to do this on the right side, if that makes sense. So like it's easier when the right leg is down, it's easier to get that right side of the door than when the left leg is down, getting the left side of the door.
Got it. Yeah. So then that would tell me that you're more limited in left ER than right. Because the bottom leg should be in more relative ER than the top leg.
Mm-hmm.
And just based on, especially if you're having any trouble getting the knee to come down, because if you think about the outside of the knee being lower, closer to the ground than where the ankle is, that would be more ER, right? And if where your bottom leg is, if everything is flush, then at least your bottom knee and bottom ankle are in the same relative plane on the ground, where the hanging leg is probably not going to get to the point of where the ankle is.
Right.
All right. So, yeah, whatever side on the bottom is easier to touch, the walls probably has better ER.
Okay.
I might confirm that, with a table test.
Yeah.
But I think, again, you want both sides, and your focus is oftentimes going to be the same. It's like, okay, if you're trying to get ER and you're feeling one side is coming more away from the door, then you want to inhale into that side to get it more into the door.
Mm-hmm.
And then that would be your focus there to promote ER, right? That posterior orientation.
Yeah.
And that would be a relative counter nutation. You're trying to get more counter nutation on that side.
Mm-hmm.
And so if you can visualize, I don't know, for me, it's visualization super important with breathing. And I do think there's some evidence behind this. It's just, it might not be looking specifically at breathing, but it just, like when you have to get better at a skill. So if you have, here's the sacrum here. I'm thinking about like this area right here, right? The base of the sacrum, and then maybe to here and to here if I'm going to bias one side. Because if I'm going to counter nutate, I want the pressure of my inhale to move this back. If I'm going to one side, then I'm going to move that back, and then underneath the coccyx is just going to move slightly forward. But that's where my mind is when I'm breathing. I'm trying to think about that, but then I might also think about bringing this back. Now you may not get like perfect contact with this part of the sacrum. It's because of just where it is relative to the PSISs and things like that. But you do want to think about that area moving back.
Mm-hmm.
So that's why you're thinking about contact centrally here happening more, not moving away from the wall there. If my tailbone touches the wall more, but this comes off, then I'm going into more nutation.
Okay. Yep, that makes sense.
So that visualization in your own head, even if it's not perfect, is valuable because you're directing your breath, you're directing your pressures there. And that's really like what we're looking to do with motion is just direct better. We just have to know where we're going, and it's got to be subtle, because if we direct in a gross manner, oftentimes we don't do anything for relative movement. We just take stuff that already moves together and just keep moving it together. So we get the absolute motion more than, right? And I think owning your breath is the best way to get relative motion. But you got to put yourself in good positions to feel that control of the breath and bias different areas.
Mm-hmm.
So any sitting position is valuable for just getting shit down, right? And especially if you're in a sitting position where you're using some vertical plane to get you somewhat stacked, where your respiratory diaphragm is over your pelvic diaphragm. But then it's just going to take time to feel that subtlety and feel those contact points changing, and just understanding like what you're trying to go for. So if you are trying to ER, and you won't feel more contact on the posterior side into that vertical contact, that vertical plane.
Mm-hmm.
That makes sense?
Yeah.
And then, but even with the IR, like I think what's confusing there is, well, does that mean that we want to go into more of that touch the coccyx to the wall? No, not for the straight leg raise there, because that's going to end up being more lumbar extension. But the other piece is that's just going to orient your pelvis forward.
Yeah.
So you still focus on that contact because you want that stacked relationship between respiratory diaphragm and pelvic diaphragm, but now you're going to maybe have more of a focus on what's happening with the concentric, just because it's easier to feel there. All right, and if you have somebody who's just really needs more eccentric, maybe you don't put them in the long sit as much. But I wouldn't be afraid of it, because I don't think that you do anything in isolation, right? So your early interventions, if you're a physical therapist and you're looking at making change, will be geared around the thing that the person needs the most, so it's easiest to see the change. But I think in the maintenance of your own body, you're doing both. Whether you're a wide or a narrow, right, you're doing both. Now, if you feel like doing one takes from the other, then maybe you go back, you know what I mean, and do that. But you need to feel both, and otherwise, you're in this fear avoidance place where it's like, oh, I'm a wide, I can't put myself in like a 90-degree, I can't put myself in a half squat position. Yeah. No, like, can you feel the change of pressure when you breathe in that? Can you understand that there may be a bias to feel something better in one position than the other? So both, I think, are valuable. It's just like you're not going to gain a lot of mobility. Well, in your case, you will, because you need both. You know what I mean? But, I guess in the traditional archetype, you just might not gain a lot of mobility in that half place. But I think it's still important to be able to maybe decrease pressure and feel the idea of like deep to superficial with your breathing, and understand that concentric element a little bit better. It's just some people that might not be ready for that. They might, no matter how much you cue them, no matter what position you put them in, they may be just too high threshold. Right. So then it's better to go into the more eccentric stuff.
Yeah.
But I think it's important to talk to your patients and get a sense of like how much do they think they understand what you're asking them to understand. Like, so how much do you understand what I'm asking you to understand there? Like, can you feel the subtleties of that difference? Do you think like that's something that you can improve on with practice? Mm-hmm. Just being there.
Yeah.
Or do you feel like you need some other intervention to make that actually worthwhile?
I think the long sit is like, I think it's too hard for me to get that in that, which like to me kind of makes sense, because I think when we measured my straight leg raise, it was like 60 something, or like it wasn't, which I'm just like visualizing it in a similar position there, and it kind of makes sense to me why it's a struggle for me to get my sacrum to get to the wall there.
Right. So what if you now go back to the wall with the long sit, and say you put like a half foam roller or something under your knees, or you just keep your knees slightly bent, like use something at first, but then
can I put a book?
Yeah, use several books. Figure out where you feel you can take the extension out of the knee. So you can elevate your hips. Or you can take the extension out of your knees by flexing the knees, right?
Yeah.
So this is one option, right? Yeah. So now you're not as much in that, or maybe you do both, right? So now you're bending your knees and you're elevating your hips.
This is like easier, but I still have to get them at least to start bent. Yeah. Then I probably put something under my hands, but
reach. One of the things that should become pretty evident here, so if you think about what do we do with like core work, just imagine like an L-sit, right? And having your arms on like parallel bars, doing an L-sit. And how hard that is to control without like tipping back, without shrugging your shoulders. Well, imagine this as your preparation for an L-sit and just how much more you're going to get out of feeling stuff deeper.
Yeah.
You're giving yourself the contact point. You're basically taking the hard position, which is worthwhile to attain, but you're imitating the shape with support and assistance. Just like you would with the deep squat, where it's like, I can't get there under load, I can't get there with my body weight. All right, just hold on to something. Yeah. Now you have an opportunity to manipulate yourself with lower tension to maybe get into a posture that you couldn't get into otherwise, and now you can breathe there and you can explore there. Mm-hmm. So with the L-sit, it's just, or the long sit here, you can elevate your hips first. So what does that do? That takes you a little bit out of away from that 90-degree position, which your body's not able to get to. And then you can, breathe into that and see, can you feel the breathing any better? Can you feel that concentric engagement of the pelvic floor ascension there? Can you make more contact? Now take the books away and just bend your knees as much as you need to. Okay, so start with your knees like quite a bit more bent than that even.
Well, the issue is there, like my knees just want to fall out.
All right, so like you can't, with your hips not elevated, there's no way you can make contact with the door.
I mean, I can get it. Yeah, I guess I can get it there a little bit.
Okay, and then can you breathe there and see if that improves over time without creating some type of symptom either? Because the thing you have to be careful with here, if you get concentric in the wrong areas, you might feel a lot of like too much adductor, too much like hip flexor area, trying to not have your knees fall out. But if you feel the areas that you want to feel, then it's fine. If not, you need to make it easier by elevating the hips. Okay. Yeah. So you have two options for progression, and it's really whatever one you like better. But you're trying to focus on the same thing, and you're trying to get to the same place over time, which would be like you can get your legs straight with everything staying on the wall. Now, you don't need to get there to progress either.
Right.
You just need to move in that direction. Okay.
Yeah.
So that's what I'm a fan of using the ground, using the wall as a way to adjust and see where you're at. Now, we can't really correspond that to saying, all right, that's a straight leg raise or that's ER, IR exactly. But I don't know that you need to. Like, you can just make the assessment, the ground sitting position that you're going for, and you get a real good awareness of what you can't do, and then you can see yourself doing it better. Mm-hmm. Okay. But you do need, I think, those fundamental mechanics of how you're trying to breathe and what contact points you're trying to get. And then that, I think, you can associate to, more ER, more IR, generally, relatively, right? More towards counter nutation, more towards nutation, more towards an ascended pelvic diaphragm, more towards a descended pelvic diaphragm. Mm-hmm. Yep. And then the last one we'll look at, and there's more that we can do here, but we can go with the Z-sit. Now, we can use a wall, but we won't do it at first. So let's just try to keep that 90-90 position of your hips. And I just want to see where you are. Where is your torso when you do that? Okay. Move the left ankle a little bit away from your butt. Yeah, that way. Just a little bit. And we'll say that's about 90-90. Okay. All right, so the first thing I would look at here is, do you need to have that right hand down?
I mean, I feel like I'm just doing a crunch to stay up. But.
Yeah, okay. So that's your assessment there. We can just make this its own assessment, right? It's okay, do you need right hand contact? All right, can you take your right hand off now and put it on your right knee. All right. And then you're at like, now would you be able to spend 2 minutes there?
I mean, like, yeah, but not
fighting for it.
Yeah, it would be too high threshold.
All right. Can you touch your left hand to your left heel? That's another assessment. All right. And then, so we can look at it as,
I start to get some hip flexor if I
yeah.
go.
So that's your assessment there. Like, you need right hand contact there. Mm-hmm. You can also be even a little micro progressions would be walk your right hand closer to your right knee, but keep it on the ground.
Yeah.
All right. And then notice if your right knee starts to come off the ground too. So that would be an assessment that you're going more to the left, but in order to do that, you have to change something on that right side, right? You have to orient everything over there, so it's not real left hip either.
Yeah.
So that would be something that we can just look at as, okay, your goal would be to breathe in such a manner, to engage in such a manner, or support yourself, right? So how would you get yourself more over to the left just with passive support?
Just elevate my butt.
Yeah. And you can elevate your right hip more than your left, right?
Yeah.
You can put a wedge under your right hip. And then if that's something that you can spend time in, and then breathe yourself to the left, basically. So now if you want to get IR on the left, you have to be able to create an in the socket, concentric, so you can think it still starts from the center out. So it's just, you're trying to get in, maybe transverse abdominis, like belly button inward, pelvic floor upward, but then you're also trying to get internal obliques, right? Things that turn you that way. A feeling of adductors. If you can, you're kind of open into abduction there, so it would be hard to feel. But if you can touch your left hand to your left heel, you can also create a hamstring moment there, right, of in the socket. So that would be the progression over time, and that's where I would say if you can't make that left hand to left heel contact, then you need to elevate. You need to make it easier, right?
Yeah.
But that's an assessment for you, and then switch to the other side. All right, and get that right one a little bit more to a 90 degree there. All right, which one's harder?
Like, they're pretty equally hard, but this one's just like I think I struggle to get into the position in like a similar part of it. Like I feel it in a certain way, but it just feels more comfortable to spend time on this side.
Okay.
It just feels easier to a point, even if there's not more motion.
Can you take your left hand and put it on your left knee? Let me see what that looks. Yeah, then see that right knee comes up?
Yeah.
Yeah. So from a motion standpoint, and what you feel subjectively is just as important as what we would try to make up objectively. You know what I mean? It's because it is the objective stuff. I think it's all relative to what you're going to be able to compare later.
Right.
But you'll be able to compare your subjective more than any therapist would be able to compare your subjective, right? Like, I mean, I can ask you questions and write them down and have you do questionnaires, but the subtlety of what you feel subjectively is going to be on you, and it's going to be on the patient or client. So just making them understand that, I think, is really important to say. It's, we're looking for range of motion, but we're also looking for like just a sense of ease that is going to be harder to measure.
Yeah.
But you'll be able to assess that. So I always like to ask that and make sure that is, at the forefront of something getting better. It's just like, okay, can you spend more time there? Because if you want to spend more time there and there's an ease in spending time there, well, now you could probably breathe better there. Now you can probably feel some subtleties there. But you're also going to tend to be more compliant with these interventions if it doesn't feel like it's absolutely awful there. So that's where you have to make it easier right off the get-go with assistance, or you wouldn't want to use that as an exercise with the way that we have it there, because you'd be too high threshold with it, like you said. But you can easily just add some support, and now that is your exercise, right? So your assessment would be without support, but your exercise would just be the same thing with support. Mm-hmm. And whenever you can do that, I find that to be super valuable, because it's easier for you to understand what you're seeing. It's easier for the client to understand what they're going for. And then you just have to be monitoring, like, are they doing what you're asking them to do? And if that's hard for you to see as a clinician, then you probably want to find something that's easier for you to see that they're doing what you want.
Yeah.
Okay. But then you got your markers, like, is it painful? And painful being specific to one of their complaints. Or if in a case like that, that you don't want them to feel stuff too anterior, right? It's not that, they're compressing bone on bone. It's just that that's not what we're looking for. Well, there's some information there that's just, okay, like, you could take it to that point, but can we get it out of there?
Yeah.
All right. And can we do it with breath and cueing, maybe internal cueing in some way, or do we need to do it externally with some type of support? Or is the position too damn hard? And then it's just like, we got to find something else.
Yeah.
Okay. But for a lot of people, like, those ground setting positions aren't too hard. It's just, you have to find the right support.
Yeah.
And sometimes you need to have, like, the right equipment for that support. Like those plyo boxes, those soft plyo boxes that I have, they're fantastic because they have enough width for people to actually sit on, and then you can elevate them quite a bit more with some of these ground setting positions. Yoga blocks work great because they are, able to be adjusted in 3 ways. And then those wedges are fantastic, those foam wedges, just because you can start to sneak them in a little bit, you can take them out, and you can educate your client on, it's like, okay, we have 2 wedges stacked, but you're taking half of the 3rd wedge off. And that's where you're able to breathe, and that's where you're able to feel your body, like, relax, and you're able to spend 90 seconds to 2 minutes there. Where I've really found that valuable is you've met him, I won't say his name, but he post knee replacement.
Mm-hmm.
And because he's not a physical therapy patient of mine, he's a training client, I've gotten to work with him for much longer than I've ever worked with somebody who's had a knee replacement. And normally what you get after a knee replacement, even if it's like 6 months that you're working with someone, is just some of these things with their knee range of motion, you just assume you can't go any farther, and you don't mess with stuff, right? Like, okay, I've gotten their terminal knee extension, but knee flexion especially, you don't think you can get somebody, kneeling and sitting on their feet and working towards that, and getting deeper into an assisted deep squat. And it takes a lot of time to do that, but the best way and we've been making a lot of progress with just getting him to sit his butt closer to his feet, is just taking, initially it was like 3 wedges and one of those AirX pads, and then it's just taking wedges away, but just really having him sit there, spend time, and breathe. Sit there, spend time, and breathe, and make sure he's comfortable with it, because he's a high threshold dude, and just, like, educating him on it's like, it's about making it easier, not trying to force anything. But that's, it's just cool to see that change, and it's very obvious. It's like, well, this is the position I want you to get into, because it's functional to be able to, if you can get on the ground and sit on your feet, like, from a knee flexion standpoint, there's very few things that are more functional other than sitting in the bottom of a deep squat. Mm-hmm. And you get this compression, but you need to fill that, because if you don't fill that, then their high threshold just try not to collapse, and it could be dangerous, right? But if you fill it, then it's safe, and then you can really be micro in your progressions of taking that away, and it works as long as you can get somebody on board to understand what you're trying to get them to do. Mm-hmm. And it needs time. So to educate someone on doing it themselves for an ongoing amount of time and being consistent is super important.
Yeah. And that's where it's helpful that he's a, training client in physical therapy, because you have, like, infinite amount of time or whatever. So
yeah, as long as is willing to be a client of mine. And this is the thing too, that being some type of hybrid of trainer and therapist, it's going to be a completely different experience than the episodic nature that we would work with someone in a clinic. And again, it's not better or worse, but you do have to appreciate that it is very, very different. So what you're getting from your physical therapy education that might orient you more to what happens in a clinic with that type of timetable, might leave a lot of stuff out. Right. And even research questions that come from that might be limited because you're not seeing people for a long. You're trying not to see people for a longer period of time. A lot of times, you're trying to say like, what is the amount of time that this particular structural diagnosis should take? Which is, what does that mean? You know what I mean? It like, if you, especially if you're not really treating the structural diagnosis, you're treating different movement problems, right? So better questions would be like, okay, how long over the course of like a long follow-up, like would it take to totally max out knee flexion after a knee replacement or something like that? But you know, you have such different presentations that it's hard to get those, to understand all those variables. I just think you stay in a process, right? Like you stay in a process of sort of progressively overloading, or overloading might not be the right word, but it is the same thing, progressively adapting people into positions that they get more and more comfortable in being. And it takes sort of as long as it takes, unless you're seeing no progress. But sometimes it can be very slow, and sometimes it's often not linear, because it's not like, okay, all I got to do on day one is just put them there. Well, you know, they might have too much pain to even try it. They might not have any idea of how to really relax and create what you're asking them to create from a breathing standpoint, from a difference between high threshold, low threshold standpoint. But the education is still necessary to get them there. And it doesn't mean like because of the diagnosis it's impossible. And I think that's sometimes what we will get, or surgeons will tell the patient. It's like, yeah, this is all you're going to get. And it's like, you don't know that. Like, you know what you're doing structurally with the surgery, but you're not part of the process after that. And I don't think there's a lot of education or even like assessment on what happens in an ongoing process if you have continually like a continuous process of trying to gain this stuff while doing other things. It's not the only thing you're doing. It's just like, and you know, why wouldn't it change, you know, over time?
Yeah.
So I think it's similar when you don't have a surgery. Well, you've had surgeries, but you know, so you got your fair share of, you know, scar tissue or whatever. But it's, as long as you take it gradually enough and you follow these sort of rules of what you're trying to shoot for. Like, all right, can you control your breath? Don't go into a lot of pain. Like, use pain, but you know, don't work through pain. And then understanding the loss of position piece, because you're trying to get relative motion and your body's not really going to want to go there, so it's going to want to move several joints at once. Having the right blockages will help you understand that relationship a lot better.
Yeah.
And then it becomes time to just feel that change.
Right. Yeah. I mean, like, the constraints is so like just back against the wall, trying to get everything against the wall there. It's just such a helpful external constraint that it's the way thought, and it just makes you feel
it is interesting. It's like, it's simple, right? But I think you have to know how to use a constraint like that too. And this is where, you know, all the work you've done, all of these models, Bill's model, PRI, where it's like they really help you understand these full body relationships. And it's really from the breath out. Like, the thing of it is, like, when you understand how a breath can work in the body and maybe optimally works, then you can go from there. And every position that you may have done before, every stretch you may have done before, just becomes more valuable. You know? And you know when you're not controlling it, you know when you are.
Yeah.
And you know, and you have different rules for what that means to control it and not.
Yeah.
And then you have more decisions to make too. Like, I don't like to be someone who is trying to tell other adults what they should and shouldn't do, especially because I'm usually younger than most of my clients. So it's like, why would they listen to me? But it's a matter of saying, like, I want to give you more education so you have more options. Like, here's the decision if you want to just kind of push your body to the limit and just get, like, say, a PR at all costs. there's nothing wrong with that, and I've done that, and I plan on continuing to do that when I'm in that mode, right, as an assessment. But I also will know what that feels like versus having control of a movement and my rules for control that I'm trying to have as a check, boxes to check, and just say, okay, I'm hitting all of these markers of control in this particular exercise right now, and then I know when I'm losing them, maybe to just get a bell overhead or just come up from a deadlift or something like that, and knowing what the intention is at any moment.
Right.
Like I've been messing around with a lot of trying to figure out how to do some like hypertrophy stuff at home, and it's not hard. It's just a matter of saying like, all right, what exercises like can I get the most time under tension, the most volume, without having to have big weights. Right. But you realize like that type of work, to get more out of it, has nothing to do with relative motion. Like hypertrophy doesn't care about your relative motion.
No, it's like
it shouldn't. It doesn't care about your technique either. Yeah. It really doesn't need to. It's just like, can I get more work in less time a lot of times, right? So, it's like cheating with technique, whatever that means, is good when you're trying to get more time or attention. You just have to make sure you don't crap out and hurt yourself, right? Yeah. But
and keep in mind, like with cheating, that you're still hitting, like you're still achieving the goal of whatever movement you're doing.
Exactly. So one of my favorite things to do, because I practiced it, is like I'll start with pull-ups, and then I'll go into kipping pull-ups when I get too fatigued. Because just doing a lot of volume of pull-ups, it's like I just feel jacked when I'm done. Now, immediately, like I lose motion, but then I'll balance. You balance that out.
Yeah.
But it's like the idea of trying to keep perfect technique or perfect positioning, or just like a rigidity. I don't think that works as well for actually building hypertrophy in a short amount of time. Like I'm not a bodybuilder, so. But I've read that in the past with like Arnold stuff. It's just like, it's like do your set to failure, even if that means you lose like some imaginary perfect form.
Yeah.
But you just have to be careful, like because you are almost you're not caring about control as much as you're just caring about like volume. And then when that becomes the case, it's very easy to overdo it. So hypertrophy is also typically not about health.
No.
It does feel good.
Well,
It feels so feeling good is also part of health, and it just becomes a different question. But it's like we have to always be asking like, what's our intention? What are we doing for somebody? And that's where like making any stance or judgment in one way or the other, like if we look deeper, we're going to be full of shit. So it's just like we have to understand like, all right, what's the relationship? What are we trying to help this person with? What are they asking for our help with? If it is hypertrophy, then it's going to be maybe on the opposite side of what we're talking about with like relative motion. We also have to make sure that people really know what they're asking, right?
Yeah.
So like there's got to be a gradual progression into that if that is really what they want. But it would just be like, okay, like this isn't, there isn't a real safe, perfect way to do this unless we really balance it out with something that is very different.
Right. And then at that point, it's like, well, it's hard because you're spending time doing something else that's not contributing to the goal that you want to get to. And it's like, how much time do you want to spend on that?
But I'm a big fan of the idea of periodization. I don't think it's the way that it's traditionally used for athletes, but just like the idea of do put yourself into something for a certain amount of time, but give yourself a finite amount of time to do it so you can then do something else. Because if you're always just trying to do everything, well, like shit gets watered down.
Yeah.
And it's also, I feel like, more stressful sometimes to do that, just because it's like, okay, you learn more that you can be doing, and you're like, you feel like you should be doing everything. Where it's like once you get into a mindset where it's like, this is what I'm focused on for this amount of time, and I'm gonna throw in some stuff if I need to support my body so I don't hurt myself in the process, but I'm really just putting my focus on this, and then later on I'll do something else.
Right.
So you're always in a plan, and sometimes that plan is just to be varied and play, right? But there's still a plan there. It's like, all right, well, now I'm not going to be so structured. I'm going to do one day hypertrophy, one day, whatever it comes to my mind on a certain day, like that could be fine to do for a certain amount of time. But it's nice to give yourself like a finite timetable where you're going to do that.
For sure.
So let's do one more thing, and then we'll go with like one or two questions today. But let's go back against the wall, and I want you to try to do your deep squat with your back against the wall. So I'll show you what I mean, what I want you to do. You can see me, right?
Yeah.
You see the wall?
Yeah.
Let me take this out a little bit. So I want you to try to keep the spine on the wall as much as possible. Now you're going to get to a point where you're going to have to sort of readjust when you get to the bottom. But let's say I get all the way down here. Now I'm down as low as I can. I know you can't see me, but I'm trying to keep my sacrum again on the wall. Trying to keep the back of my head and trying to keep my shoulder blades on the wall. And then I'm going to try to, well, first I'll feel like, how does that feel? How deep can I get? Do I have any pinching? If that feels okay, then it would be adjust your feet so that they come closer to the wall too, so your knees are more forward. And how close basically can you get your heels to the wall without losing some of that contact, without having symptoms. So now I'm down here. What I like to do personally is get to the point where my heels actually elevate. Like I don't want them to stay down the whole time. And then I want to breathe them closer to the ground. So right here, my heels are hovered. And then I'll play around with reaches, or I'll just try to feel like if I just want to rest my arms here, can I feel expansion where I want to feel it? Can I exhale more medially, like medial part of the foot, thinking relative pronation on the exhale. Inhalation, I'm trying to relative supination, but nothing's moving a great deal. I'm focusing on more that posterior expansion on the inhale, and then exhale, ribs down, trying to feel everything I want to feel during the compression. But just having that contact, is that something you can spend time in? That's the question, right? Because there's a lot of things that can be uncomfortable here. But that would be how you can use the wall for your deep squat. Without the head, you can also do this on like the base of a couch.
Okay.
You're not going to have your head touch, but you can have your sacrum and lower back and even up into the mid back a little bit have contact.
So I want my sacrum can't leave the.
Yeah, that's for what we're focusing on here. So just imagine where the center of your respiratory diaphragm is and the pelvic diaphragm. All right, and then when you go down lower and lower, like the wall would be your indicator that they're staying on that line. Okay. Now, if that's your limit, see if you can lean forward, right? Find a way to get through that sticking point and then sit even lower. Right, so like use your hands. All right.
I lose. Sorry, this wall's not very slippery.
But it might not be a bad thing because once you get down there, can you find, all right, now can you create a pressure back into the wall there? Does that create symptoms?
It's like I get a little pension for sure.
Okay, then that's not for you.
And knees want to go out.
Mm-hmm. Yeah, so that's not for you yet. But you can see that's the same idea of what we were doing with the ground sitting. Because a really good deep squat is a seat.
Yeah.
Right? And I don't want to say good, but like a mobile deep squat. You're sitting on yourself. All your anatomy is able to come in contact without, so heels to the ground, back of the thighs to calves, hand and belly to thighs in some ways, right? So that's just another version of a seated position that you would just use the wall for. But symptoms would say that that's not for you.
Yeah.
Does that make sense?
Yep.
Now you can explore different ways though to get there. I would want you to be able to find about that hip angle with maybe holding on to doorknobs, holding on to like a TRX, holding on to a pole,
Mm-hmm.
and then be able to breathe there and create that similar compression.
So like but like can back round on that? Like if I go here?
So what I would want you to do, so what's the difference there now, right? Because you don't have the wall, right? So everything is like,
Go back.
yeah, you've oriented everything back. It's like if your upper back is actually behind your sacrum right now. So what I would look to do is come up, keep your hands on the doorknob, try to create the compression from the top down. So move your butt back, like walk back a little bit more. Arms stay straight. Put your belly on your thighs before you bend your knees, right? Like, all right, can you be there? Now you can bend your knees if you need to bring your thighs to your belly. Don't drop any lower though. So just keep working back. Does that pinch?
Not really, no.
Okay. Now keep a sense of staying through your heels and staying back as you then have your hamstrings and calves come together. Okay. Do you get any pinching there?
Not much, no.
Okay, and then just keep sitting. All right. Still good there?
Yeah.
And now this position, you should have a lot more compression lower, right?
Yeah.
So you definitely have flexion on the backside, but what you want is to get that compression on the front side there, because now that could be some of your feedback for where you want to breathe.
Yeah.
All right, so if you can inhale belly into thighs, breathe into your groins, then on the backside you might feel that area of the sacrum moves back. And then when you exhale, maybe you can pronate a little bit more, like you bias more the inside of the foot, inside of the heel, in the socket, ribs down idea, eyes up, so like keep your head position up a little bit more. And this, initially I would start with just feeling this as low as you can, not caring so much about what's happening up higher, but then eventually you might be able to bring yourself up. If you turn your palms up right into more supination, it may change what you're feeling up higher to. Okay. And then when you come out of it, I would just try to keep belly pinned to thighs, butt back, and then sort of roll up. Yeah. Okay.
It's tough.
So that's how I would do deep squat work when you don't have the wall.
Yeah.
I would bias more of the compression on the front, all right, because otherwise you're just going to fall back, and then you just don't get any feedback, right? And you're not really improving what you're limited in. So you're trying to improve that belly to thigh, right? Like you're limited in that hip flexion.
Yeah.
So that would be what I would bias, like make contact there first before you drop down, and then you make contact hamstring and calf without losing the belly to thigh. And then the heels will stay down, and then you can breathe there. Once you get more comfortable there, what you can explore is, all right, what would it feel like if I took my hands off the door? Would I fall on my ass?
Yeah.
Yes. So what direction would you have to then be stable in to not fall on your ass, right? Now you're not going to have enough, you're not going to have enough force in that direction to make a big difference there. So, and a lot of times that's going to be like knees more forward idea, right? So that's where I think that exercise combined with the one against the wall, where you're bringing your feet progressively more under you, your heels closer to the wall, those two work well together. Okay. So there's not like one right way to squat. Like if you look at the bottom of that squat, and I would look the same way if I'm holding onto the doorknobs or I'm holding onto a pole, there is going to be a lot of flexion. You might feel it in your lumbar spine, but you're held in a position there's not going to be too much load there that's unsafe.
Right.
But you get that contact in the front, and that's really valuable to be able to create that AP expansion around that area. So should be helping the ER down there. just because you're getting some of that movement in that direction. And then can you feel that descension of the pelvic floor as well down through there?
Yeah.
All right. So that's the one I would do. I think even before doing heels elevated, I mean, you said you do pretty well with the heels elevated stuff too.
Yeah.
But you want to find that compression as much as you can centrally, like, you know, your legs a little closer together, and just be able to breathe there.
Mm-hmm.
And then connect that to what you're doing with the heels elevated. If your stance is a little bit wider, you won't have as much contact belly to thigh, but you'll have more of probably a rotation, you know, like in the femurs.
Yeah.
But it won't be necessarily as much feedback to breathe. But if you can feel the same mechanics of breathing with that heels elevated one as you can with the doorknob one, that's what we're looking for.
Right. Yeah. Okay.
Okay.